benign early repolarization, it's exactly that.
I don't know about that. Gwenny is a fantastic educator, and she makes great content for both nurses and paramedics, and you should be following her. But the notion that early repolarization being benign is moving closer and closer into myth territory over the last 2 decades. So let's talk about it. So benign early repolarization, or early repol, can be recognized on an ECG with a high takeoff point of the ST segment, essentially ST elevation that can resemble myocardial infarction or pericarditis. Here's a few things that make early repol identifiable on a 12-lead ECG. The first thing is this concave shape to the ST elevation. You don't usually see this sort of morphology with myocardial infarction. Another thing is that there actually won't be associated reciprocal changes. Another very recognizable finding in early repolarization is this notching of the J point, or what they call a fishhook. Now, for the longest time, early repolarization was thought to be benign, hence the term benign early repolarization. However, there's been more and more research coming out that finds anywhere between a 30 to 60% association between early repolarization and idiopathic ventricular fibrillation. Basically, somebody suffered cardiac arrest for no apparent reason. And that's compared to about 5% of people in control groups. There's also an association between recurrent ventricular fibrillation and early repolarization as compared to control groups. And in those patients who have survived idiopathic ventricular fibrillation, they are now diagnosed with early repolarization syndrome. Now, there's 3 different patterns of early repolarization that are classified from low to high as far as their association with what's called ventricular fibrillation storms. Type 1 occurs in the lateral leads. There's a low association with VF storm there. Type 2 occurs in the inferior leads. There's a moderate association with VF storm there. And type 3 is global, and there is a high association with VF storm with type 3. Now, I said patterns, it's actually locations, but there are actually 2 proposed patterns of early repolarization: the benign early repolarization pattern and the malignant early repolarization pattern. Now, the thing about the malignant pattern is that a large number of patients where you can recognize that malignant pattern on their ECG share a genetic mutation with patients who have Brugada syndrome. If you want to read about this on your own, I'll put a link in my bio to a Life in the Fast Lane article on this. A lot of what I just covered can be found there.
You're going to be replaced by AI. You know that, right? Right now, there's AI programs that will listen to you while you're on a scene, and then it builds your PCR for you to a fair degree of accuracy. There's AI that interprets your ECGs to a degree of accuracy that you could never achieve. There's AI that interprets chest x-rays. There's AI that interprets your diagnostics. There's AI that interprets all imaging, and it's very accurate. You know, right now, EMS agencies are just looking to put butts in seats. There's a lot of EMS agencies that will just hire someone with a pulse. Imagine if they could just put an EMT through an accelerated paramedic program that really is more designed around working with AI. You show up to a scene, you have AI listening to your assessment, it uploads your diagnostics and analyzes the diagnostics, and then it prompts you as to what you should do to help that patient. I don't think that this is wildly speculative. I think that this is a future of paramedicine that we've all been denying, and that is almost inevitable.
My question is, how would you feel if pharmacists were involved in EMS? But like assistant medical director, where we teach all the paramedics and EMTs about medications.
It's nice to meet you. I'm Jimmy, the EMS Avenger, and I appreciate and respect your passion for education. It really resonates with me, and I promise I am making this video in good faith. So I would be absolutely all for this. I think that EMS should learn their pharmacology from pharmacologists. They should learn their obstructive lung pathologies from pulmonologists. They should learn airway management and intubation from anesthesiologists. They should learn cardiology and cardioelectrophysiology from cardiologists. They should learn diabetes management from endocrinologists. But the question I would ask is, how practical and pragmatic is it for an EMS service to run the gamut like this? And why does pharmacology get a seat at the table first, say before pulmonology or cardiology?
You figure we actually don't push many medications during the course of our day, and the ones that we do, the most common medications that we administer are Zofran and inhaled beta agonists. In fact, the most common calls that EMS run are abdominal calls, so why not bring on a gastroenterologist? We also push some analgesics, including fentanyl, and, well, maybe we need to bring you on to talk about the pharmacokinetics of fentanyl, because public service needs some help there. Speaking of AI, the must-have app, the app that you want if you want AI assistance in interpreting ECGs, is PM Cardio. And it's now available to individual providers. It used to be that you had to be attached to a service that used PM Cardio. Now you can download it for yourself and get a certain amount of tokens every month to use. And it incorporates the Queen of Hearts AI technology, which meets or exceeds STEMI criteria and expert interpretation as far as determining the presence of a myocardial infarction. Not only that, but when you upload your ECG, it digitizes it and makes it a clean, readable ECG if there's artifact on it. Now, this wouldn't be for like every single ECG that you perform. This is for when you have that patient that has that compelling story, that high pretest probability. But then you look at the ECG and you're like, I'm just not sure. This is when this app is really going to serve you. This has been clinically validated, and if you've kept up with Dr. Stephen Smith's ECG blog, you know that he continuously advocates for its advocacy. I have no stake in this. No one is asking me to produce this or say this or promote this. I just, as a service, want you to know that this technology is out there and is a valuable resource. And if you want to read some data about it, I'll post a link in my bio, and the app is called PM Cardio. This is part 2 of my discussion on AI replacing paramedics. And before I get to the whole AI giving the middle finger to degrees, I do want to clarify one thing. When I say that AI would replace paramedics, I don't mean that it would replace the physical person. A lot of people are like, well, who's going to pick that person up off the floor at 3 a.m. or start an IV? You are, except that you won't be a paramedic. You will be an AEMT with an expanded scope, armed with very powerful AI tools. Now, as far as AI giving the middle finger to degrees, there's a lot of momentum right now in discussions on paramedic degrees and whether or not all paramedics should have degrees and whether the profession should go towards degree only. And there's also a lot of discussions on how EMS should be divorced from the fire department to become its own legitimate provider of care. I think that AI actually sets us back a little bit. I don't think it advances any of those goals. I think rather than our EMS services across the country looking to advance the profession towards degree only, I think they would rather just have the AI and operate exactly the way they do. And I think that pushes us back towards a fire-based efficient model. I'm not Nostradamus and I'm not claiming to be, but EMS is kind of like the stepchild of healthcare. And I think that the advancement of highly advanced AI ends up diminishing the value of the highly educated paramedic rather than revealing the need for it. Now, there's always going to be a need for intelligent, quick-thinking clinicians, but AI, I think, is going to start pushing them to the margins. What do you think? Let me know in the comments.
My team was recently dispatched to an outlying hospital for a newborn who was not thriving, and we determined that she most likely has a congenital heart defect. My role as a first responder who specializes in neonatal and pediatric critical care is to get to the bedside and then get them to the cardiac team at the children's hospital where they can receive surgical repair. One of the most important things that we do at the bedside is to contact our cardiac team and work out a plan to hack our little baby's pre-birth cardiovascular systems to get it working again until they can get to surgery. FirstNet, built with AT&T, is one of our most important team members during this time. You see, our emergency may not be the only emergency occurring in the area. Networks can have a heavy demand placed on them and become congested from other emergencies and even disasters, making the network unavailable for first responders when we need it the most. So our little cardiac baby gets prioritized over the network while we work with our team to come up with a treatment plan. If you're a first responder, staying connected makes all the difference, and FirstNet understands who is depending on that connection. Check your eligibility for FirstNet at the link in my bio.
second chance for a break that would make it okay. 'Cause all we
All right, well, I'm out there with my EMS crew. I'm responding to an 11-year-old female who is having a seizure. She has a seizure history. And so I administer my 2.5 milligrams of Versed IV. The seizure does stop, but 5 minutes later, she has another seizure. So obviously, this is status epilepticus, right?
I'm pretty sure you just brought me on here to just piss me off. All right? So looking at your dosing for benzos, right? So we need to look at always evidence-based medicine and not just doing things based on clinical gestalt or dogma, right? So looking at the Rampart trial, right, that initially looked at pre-hospital clinicians, because we always want to use and understand that we are different clinicians than in-hospital providers. So they know that giving sub-therapeutic doses of benzos does not address the underlying pathophysiology, especially in someone that's true status epilepticus. So we need to, once again, put our big boy, big girl pants on and do the appropriate dosing. And yes, we're always going to be concerned about airway, just like we would for any medication that has CNS suppressant effects. But it's going to treat the underlying pathophysiology. So give the appropriate doses, which includes upwards of 10 milligrams. And you heard that correctly. 10 milligrams should be the dosing that we're looking at for most adult patients. Now, we do a little bit different weight-based dosing, for example, 1 mg per kg in a child, but that still includes upwards of 5 to 10 milligrams is important for actually addressing the pathophysiology.
You are not in status epilepticus unless you've been given the proper dose of benzos first.
Hell yeah.
This question has to do with a video I made breaking down various positions on the administration of Narcan in cardiac arrest suspected to be from opioid overdose. And I mentioned in that video that opioids don't really have any significant cardio-blunting effects and that they may actually be cardioprotective. So let's break down the patho on how that could be. So you have receptors in your body that are known as receptors. I know that's not really an intuitive symbol. It's actually pronounced mu receptors. You know I had to do that. Mu receptors. Last time, I promise. Mu receptors handle neuromodulation of a host of different functions within your body. And what commonly binds to mu receptors are opioids. And so they're referred to as mu opioid receptors, or MORs. And you have a bunch of different types of groups of MORs. One group exists in your spinal cord. And when opioids bind to the MORs within your spinal cord, it limits the release of pain signals. You also have MORs within your heart. And when opioids, including your own endogenous opioids like endorphin, bind to the MORs within your heart, it changes the way the electrical pathways and the proteins behave in your myocytes, which are the heart's muscle cells, and it can make them more tolerant to ischemia, or low amounts of oxygen. Now, does this actually happen to patients who were in cardiac arrest? I'll put a link in my bio to a paper that was kind of like a proof of concept paper where they induced heart failure in rats, and then one group of those rats received opioids and the other was a control group who did not receive opioids, and the heart failure was significantly less in the group that received opioids. However, there's no real quality data that this is having a measurable effect on patients in cardiac arrest, that not administering Narcan to these patients is leading to improved survival and less cardiac damage. In fact, expert opinion really is that opioids don't hurt and they don't help. It's just neutral. It's time for another round of shock or no shock. You're going to be working a cardiac arrest. You're approaching your rhythm check. I'm going to show you a rhythm and you have 3 seconds to determine whether or not to defibrillate your patient. Why 3 seconds? Because that is the maximum amount of time you should be taking in a real-world cardiac arrest. So here come the rhythms, and good luck. Bidirectional ventricular tachycardia. You've probably never heard of bidirectional ventricular tachycardia unless you watched my shock or no shock video yesterday where I included that in one of the shock scenarios. And then the response from everyone is, what is bidirectional ventricular tachycardia? I need a video on that. So here's your video. Bidirectional ventricular tachycardia is a very rare ventricular dysrhythmia that is characterized by the QRS axis alternating to be above and below the isoelectric line with every other complex. And it can look like bigeminy, or it can look like alternating right bundle branch block. The key to suspecting bidirectional ventricular tachycardia is the history, because there are really only 3 things that are known to cause this, the most common being digitalis toxicity. Digitalis, or digoxin, is an old school medication used to treat heart failure and atrial fibrillation. It comes from the foxglove plant. Very few people take dig today. There are just better drugs out there that are more targeted, more effective, and dig has a very narrow therapeutic window, so it isn't difficult for people who take dig to experience digitalis toxicity, whether acutely or from chronic use. Another known cause of bidirectional ventricular tachycardia is aconite poisoning. This would be more common in other parts of the world, but aconite is a root used as an herbal medicine in some cultures, and there's literally 1 case study that I found of this occurring in North America. Another instance in which this could be seen is when someone experiences what's called catecholaminergic polymorphic ventricular tachycardia. In catecholaminergic polymorphic ventricular tachycardia, or CPVT, a person will experience syncope and a ventricular dysrhythmia after a significant catecholamine release, and that can be from exercise or like a really stressful emotional event. Treatment options for pre-hospital providers are limited. Defibrillation if it's pulseless. If not, there's been some success reported with administration of mag sulfate, with administration of beta blockers, with administration of sodium channel blockers like lidocaine. If it's dig toxicity, they're going to need Digibind in the hospital. Follow your local protocols, and I will put resource links in my bio. Resuscitation in the United States is completely broken. It is. We have completely lost the plot on resuscitation. How else do you explain someone asking, theoretically, what we should be focusing on in cardiac arrest? And that is nothing against you, the player. It's a condemnation of the game, the system. We'll have services trying to solve the problem of resuscitation by spending $250,000, $500,000, $1 million on mechanical CPR devices, on suction cups and hockey pucks. Heck, the Eligard costs like $10,000, and that doesn't even include the required Lucas. And they'll throw all this money around and worship at the altar of tech, not realizing that it's a false god. Now, there's a place for tech, some of it, in resuscitation, and it's specific to the needs and the resources of an individual service and region. But your hallmark treatments in resuscitation are quality, uninterrupted CPR and timely defibrillation. You make small, incremental improvements to your CPR and to your defibrillation strategies, and that directly correlates to small, incremental improvements in your neurologically intact survival. If every service took improving the quality of their CPR seriously, survival in the U.S. would skyrocket. And you know what? Improving the quality of your CPR really requires more commitment than money. I'm going to offer everyone a red pill or a blue pill right now. The red pill, you watch this video, The Science of CPR. Put the link in my bio. You will never look at resuscitation the same way again. You take the blue pill, you can be happy with your 4 to 8% survival. So I'm still here at Flightbridge's Fast 25, and I'm here with the LifeFlow people. I made a video the other day about the push-pull method as far as rapid volume infusion goes, and got a lot of questions. What is the push-pull method? The push-pull method is when you pull fluid from a bag or pull blood from a bag using like a syringe through a 3-way stopcock, and then you push it really quickly back into the patient. It just gets fluid in faster. And my friend here from LifeFlow is going to demonstrate what that looks like with the LifeFlow.
Sounds good. Thanks for having us. This is going to be the LifeFlow device. Push-pull is going to be pretty easy for you with our special handle that you're going to put the syringe into. For this, the tubing is going to be kind of like your standard blood tubing with 2 ports. You got your filter. You have an air check chamber. What this is going to do is this ball will drop prevent any air from going in this line, so you're never going to have to reprime your line once you get it started. So the first thing we'll do is we'll get our line ready to go, a couple squeezes. You're going to note that that ball is going to float during setup, and we need that ball to float to have flow. So we're good there. Once we're primed there, we're going to go ahead and take our handle. We're going to open up our canopy. Syringe is going to go in. It only goes in one way, numbers up. Close our canopy. And then this is the only time we're going to tell you how to hold it. A couple squeezes up just to help get the air out. 2 or 3 good squeezes. We're going to connect to our Q-Inflow warming device, and then we're going to connect to our patient. Today this bag's going to be our patient. With this being said, we have a force reducer that's built into this. It's soft tubing inside a really hard tubing, and it's going to swell up, and that will help take the hit from any smaller gauge catheters. Once the air is out, connect to our patient, start our treatment. Every pull is going to be 10 mLs of fluid. So really easy to give fluid, really fast to give fluid. You can do a liter bag in under 2 minutes. You can do a liter of saline in under 4. So it's going to be very quick for fluid resuscitation. I tell my guys it's great for sepsis treatment, it's great for blood replacement, and it's also great for your pediatric aspect of it, pediatric readiness, because every squeeze is 10 mLs, you can dose correctly.
Yep, push-pull is a great way to resuscitate your patient. You're not going to get fluid in faster than a push-pull method. I appreciate it.
Awesome.
2 things I need you to know right now. The first is the phrase too gross, and the second is the number 350,000. We'll get back to the phrase too gross in just a minute. The reason why I need you to know the number 350,000 is while EMS is training its butt off constantly to take care of 350,000 people who suffer from out-of-hospital cardiac arrest every year, most of those people aren't walking out of a hospital. In the meantime, there are 1.7 million people who will suffer from sepsis in the U.S. every year, and 350,000 of them will die from sepsis, and we can move that dial a lot. But training and recognition on sepsis in EMS is sorely lacking. How many times have you actually run a sepsis scenario compared to the amount of times you've run a cardiac arrest scenario? How many times have you had a patient where their symptoms were somewhat vague and you really lacked clarity on what was going on with that patient, and you only realize later or even after the fact that they may have been septic? This is what I need you to be thinking about when you walk into a call and your patient has vague symptoms. Too gross. GROSS stands for gastrogenitourinary, respiratory, open sores, and surgeries. These are conditions that are very likely to progress to sepsis. And then if your patient is gross and you have combinations of vital signs that are too high or too low, too fast or too slow, you should be thinking sepsis. And you need to act as purposefully with these patients as you would with someone in cardiac arrest. In fact, just letting your patient's blood pressure in these situations drop below 100 systolic one time results in a 3 times higher chance of mortality. So remember, if your patient is gross and they're too high or too low, too fast or too slow, think sepsis and be aggressive.
Paramedics, EMTs, EMS, I am an LVAD patient, and I'm going to explain some stuff to you.
Yes, yes, yes. I love this video. This guy is a great example of how to reach the minds and the hearts of EMS personnel. He's educating EMS personnel on LVADs with love and kindness. I cannot love this video enough. I've been tagged so many times in this video, and I want to amplify this video, so I'm reposting and I'm posting the link to this video in my bio. There's not much I can add to it, but I do want to talk about one thing that he mentions.
The Lucas machine, probably not a good idea, but manual CPR.
Yes, there is a theoretical concern on the use of mechanical CPR in patients with LVADs. However, there is a paucity of evidence in general about the safety of CPR in patients with LVADs. There are some observational studies that show that manual compressions have not dislodged the LVAD. However, there is a case study out there that was published 2 years ago of a 53-year-old woman with an LVAD who went into cardiac arrest. A Lucas was placed. It did compressions for 2 hours before she was resuscitated, and the LVAD was not damaged, it was not dislodged, and it was fully functional following resuscitation. In fact, the Lucas may even be safer for a patient with an LVAD than manual compressions. The Lucas actively measures the resistance of the chest when it's performing compressions and only applies the pressure that's required to compress the chest to the required depth, whereas a human may overcompress the chest in their excitement. With that being said, there are a lot of services out there that have protocols for patients with LVADs, and they specifically contraindicate mechanical CPR for those patients. But we have to keep in mind that years ago, we specifically contraindicated manual compressions for these patients until we actually had observational data. I am not making a recommendation that you use mechanical CPR in these patients. This is for educational purposes only. It's important that you follow your local protocols, but I will post a link to that case study in my bio. Now go watch this guy's video. The link to it is in my bio. How do you feel about EMS personnel carrying weapons? North Carolina House Bill 975 is a bill that's passed the House. It's not signed into law, but it would allow EMS personnel to carry pepper spray, whether concealed or otherwise. I'm someone that has traditionally believed that EMS should not carry weapons, they should not wear body armor, they should not look tactical. When you give the appearance and have the ability to be able to harm a patient, I think that that makes it very difficult to build trust with vulnerable people. I also think that it also kind of blurs the lines between us, a profession that is supposed to be providing care to someone, and someone like law enforcement, someone who, although they are meant to serve and protect, they still have the ability to incapacitate or harm or even kill someone. And I think that when people can't tell the difference between us, that makes us less safe. So in that regard, my initial reaction to the pepper spray bill was hard no, absolutely not. But I think my views have softened a little bit on that. I'm not in favor of every paramedic or EMT being able to carry pepper spray on all ambulances without any sort of safeguards or restrictions or conditions. But I can see where there's some specific contexts where it would be appropriate for EMS personnel to carry pepper spray to be able to protect themselves and ward off an attack. So I want to know how you feel about this, how you feel about EMS personnel carrying pepper spray and EMS personnel being armed. And I'm asking this in good faith, so hopefully I can get good faith responses. You don't need to rage at me and say, I guess I don't know what it's like to be shot at 3 a.m. I am very, very aware of the risks to our health and safety when we're out there in the field. We all know what happened to the paramedic in Kansas City, right? I just believe that when we become perceived as just another entity that can harm the community, that ultimately increases that risk rather than decreasing it.
In regards to EMS carrying weapons, I woke up this morning to more comments that I could possibly interact with. And I wanted to address something, which is this is made in absolute good faith because I want to hear what people have to say. And more importantly, I want to hear what people who disagree with me have to say, because I can have my own opinions. Those opinions are developed based on my life experiences. And while I can anticipate how people might respond, something that I can't do is possess within my hands and within my heart the passion that's behind it. I can't understand their life experiences. I can't go back and live the way they live and be raised the way they were raised. And so I have to just put out there what I think, and then I actually process the way people disagree with me, and I do consider it. I mean, I already acknowledge that I took a hard position on pepper spray and that position had started to evolve. And so I am very willing to be swayed. And I think that it's actually dangerous to be in a position where you're like, this is the stake in the ground that I'm putting in, and I'm not going to move from it. I realize that there are people out there who are like very 2A and very passionate about that, and they believe that this is an inalienable right that exists and that the government should not have the ability to restrict. The thing is that my formative years was during the 70s and 80s, and this mindset did not exist back then. It wasn't woven into people's DNA back then the way it is now, and it didn't have the socio-political overtones. I wasn't raised around firearms. My family didn't hunt, and no one was compelled to own one for any other reason, so I never developed this romance with them that exists now in the world. And so I can't possibly comprehend the passion that other people have for this. So it is very important that I expose myself to it. Even if I disagree with it, I need to plant a stake in the ground and not move as those winds of passion come towards me, so I can understand it. And so I can challenge you to a certain point that I know that your feeling about this is not just momentum, but something that you have clearly thought out. And I just want to thank everyone for all your comments, and thank you particularly for your disagreement.
You want to see blood and guts, and it's okay to admit it. I had a student the other day literally tripping over herself, trying to avoid acknowledging the morbid curiosity that exists in people that work in EMS and emergency and trauma services. Now, you probably can't appreciate this if you're not in healthcare, but when tragedy has befallen someone, when they're having their worst day, they've gotten into a wreck, they've fallen, some sort of trauma, and their femur is literally sticking out of their leg, that person taking care of you probably kind of wants to see that femur. And it's really difficult to find an appropriate way of acknowledging that what we get to do is pretty cool. Because obviously the worst things that we've seen are the worst thing that anyone's ever seen, and they are horrible and tragic. And it's also important to acknowledge that even though we may be getting a little bit of a thrill, even the most jacked up trauma junkie who can't believe some of the things that they're getting to see is still going to walk away from that with some sort of vicarious trauma.
Did you know that up to 40% of PEA actually may come with some sort of cardiac wall motion? And if you're an EMS service that carries point-of-care ultrasound, you can actually detect that cardiac wall motion, and you can change your resuscitation approach and maybe give yourself a better chance of resuscitating that patient. And this gentleman right here is going to look at my heart to determine whether or not I have wall motion present.
Does indeed.
Within seconds of determining whether or not that left wall motion is there, you can change things up, maybe give a different pressor, maybe switch to something like norepi or even vasopressin, and significantly improve that patient's chances of survival, because they're actually not in a no-flow state, they're just in a low-flow state.